Hello everybody. Welcome to another live webinar from I Love Homeopathy. Today we have a very interesting subject. We're going to talk about the thyroid gland and how homeopathy can help in many conditions where we have a thyroid imbalance. This live webinar is going to be given by Dr. Soumya. She's a postdoctorate. She's an MD in homeopathy, specializing in thyroid conditions, infertility conditions. So she has a lot of experience in this subject. And today she's going to share with us some of her experiences on how homeopathy can help rectify the imbalances of the thyroid gland. So I'm going to ask Dr. Soumya to take over from here. I'm just communicating. Yes, I've just sent her a message. She's somehow not able to hear me, but we'll get her to start.
Hello, can you hear me?
Yes. Yes, go on.
So, I can't hear anything back.
Go on. No problem. Go on.
Shall we start, doctor, or have to wait for this audio correction? Okay. So, good afternoon, doctors. Myself, Dr. Soumya Krishnan. Today, we are going to discuss about thyroid conditions. As we all know, thyroid is a very important gland in our body and which control our all metabolism. That is, each and every cell of body is controlled by thyroid hormones. So, it's a very important gland, and let's have a journey through the thyroid disorders and let's share our knowledge. First, let's see what is the control of thyroid hormones. That is, thyroid system. It is controlled by many. There is a lot of glands are controlling the thyroid system. The first one and foremost is the hypothalamus. That is our center of our endocrine system, and which controls our pituitary, that is the anterior pituitary, and it is secreting TSH, that is thyroid stimulating hormone, and that it controls our thyroid gland. And thyroid gland, the main important hormones secreted by thyroid gland are T3 and T4, and it increases the metabolism, it controls the growth and development, and it increases the catecholamine effects. And as I said, it is controlling the every metabolic activity of the body and is one of the most important gland in our body. I'm not going into the anatomy and physiology of the thyroid gland. We all know about the anatomy and physiology. Straight away, we can discuss what are the disorders related with thyroid gland. The first and foremost is a simple enlargement of thyroid gland. It is otherwise known as goiter. Goiter, mainly it is of two types. That is, first one is a simple goiter, where you can see a simple enlargement of gland. And second one is the adenomatous or nodular goiter, where you can see the nodular, on examination, you can feel the nodules inside the thyroid gland. The next foremost and most important presentation of thyroid complaint is a hypothyroidism. Hypothyroidism, according to the age-wise, it can be divided or can be classified into infantile hypothyroidism or cretinism and adult hypothyroidism or myxedema. The next important manifestation is the hyperthyroidism. In that, we have two conditions. First is the Graves' disease. It is otherwise known as autoimmune hyperthyroidism or Graves' disease, or other condition is the thyroid stone. Thyroid stone means it's a grave condition. As the name, it is a storm. It will create a storm inside the body because of the increased level of that is thyroid thyroid hormones in the system. It will produce more manifestations, and it can sometimes lead to life-threatening complications. Next, in this era, when we go through the investigations and all, the most common term we came across is the thyroiditis, and the most common term we have heard along with thyroiditis is the Hashimoto's disease. The last one is the neoplastic processes, where you can divide it into benign one and the malignant one, and we will discuss it one by one. The next important thing is the common investigation we have come across our clinic while related to thyroid disorders are the serological results, that is with the TSH, T3, T4 levels, and how we can assess the complaint of the thyroid gland by this assessing this TSH and T3, T4 values. First one is when you get a high TSH value with a normal free T3 and free T4 and T3 means it is subclinical hypothyroidism. You have to think increased TSH value, it is a hypothyroidism, subclinical hypothyroidism. And when this TSH value is below 10, it is considered as a subclinical hypothyroidism, and it is then above 10, it is a clinical hypothyroidism. And the next condition is there is an increased TSH value with corresponding decrease in the T3 and T4. Means there is a defect in the gland. The TSH, pituitary is producing TSH, but the gland is not responding and producing the thyroid hormones, which will result in the reduction in the thyroid hormones like T3 and T4. It is known as primary hypothyroidism. Means here the gland is the culprit because the gland is not working. Next condition is there is a decrease in all levels of all the hormones. That is, the TSH is decreased, T3 and T4 are decreased. Why this happen? It is because there is some problem with the central system. That is, hypothalamus pituitary axis is not working and it is not producing TSH properly, which will lead to decreased production of thyroid hormones by the gland. It is known as central hypothyroidism. And this classification is very important for our management also. So please note this classification: subclinical, primary hypothyroidism, and central hypothyroidism. Then next thing is we got a TSH value decreased along with normal T3 and T4. When TSH value decreased means we have to consider the condition of hyperthyroidism. Here it is same as that of hypothyroidism. It is subclinical hypothyroidism. And when TSH value decreased with only increased level in T3, it is known as T3 toxicosis, where T3 is the only hormone which is affected along with decreased TSH. And next condition is there is a decreased value of TSH with increased value of both T3 and T4. It is the opposite part of what we had discussed earlier of primary hypothyroidism. Here it is the primary hyperthyroidism because the TSH value because of the increased production of T3 and T4 from the thyroid gland, there is a corresponding decrease of production of TSH from the pituitary. So it is known as primary hyperthyroidism. Here the primary that is the defect is in the thyroid gland itself. And the last condition is there is an increased or normal level of TSH along with increased T3 and T4. Like that, there is a problem in the central system, that is hypothalamus pituitary axis, and it is producing the increased level of TSH, and because of that there is an increased level of this T3 and T4. Then let's discuss the conditions one by one. What are the common causes of hypothyroidism? Hypothyroidism, we all know it is the decreased level of thyroid hormone along with there is an increased level of TSH. That the main causes of hypothyroidism are, the first one is the iodine deficiency in the diet. We already know about what are the impacts of deficiency of iodine in our diet that will lead to hypothyroidism along with the goutus enlargement of gland. The next one is the inflammatory process of the tissue of the thyroid gland. It is otherwise known as thyroiditis. We have discussed earlier, that is mainly the most common cause is Hashimoto's thyroiditis. Then complete or partial removal of thyroid gland. It can be due to either either due to some malignancy or either due to some adenomas or anything like that. The partial, that is, but surgical removal of the gland will lead to decreased production of thyroid hormone and will lead to hypothyroidism. Then unfavorable environmental factors like radioactive this radiation and work in harmful production, and this will also lead to that is a non-functioning of the thyroid gland and will in turn lead to hypothyroidism. Then anomalies in the intrauterine development of the organ of endocrine system, and we may have seen the reports like congenital absence of thyroid gland, like that, etc. In that condition, there will be no thyroid gland in the body, so it will lead to hypothyroidism. Then use of radioactive iodine for therapeutic purposes, that will lead to a partial restriction of the gland and hypothyroidism. And then drug therapy depressing thyroid function. And the last one is the damage and inflammation of the hypothalamus. That is, the central system is affected, so there is no production of TRH and then TSH and in turn T3 and T4. We have already told what are the serological investigation we are doing in the case of thyroid disorders. First one is the TSH, the most common hormone that is we are investigating or we are encountering in the this thyroid disorders are the TSH level. And next one is the T3, then T4, then free T3 and free T4. Free T3 and T4 are very important in this era because you may get a normal result in the T3 and T4, but there may be fluctuation in the free T3 and T4. So when you are doing this thyroid profile or thyroid investigation serology, you have to do all these 5 hormones in the initial value itself. If you get the result of fluctuation in the TSH only, you can do that investigation only for the follow-up investigation. But initially, when a patient is approaching you or when you're sending the patient for the serological test, do all these 5 tests. And let's see one case. It's a case, she came to me when I was doing my ND, and it was found that the initial level of TSH, the patient was already under thyronine supplement, that is a synthetic thyroid hormone, and she closed all those medication and she wanted to switch over to our system, and she came to me with an initial TSH level of 150 with a no thyronine supplement, along with there's a reduction and with normal T3 and T4. So TSH level is only the fluctuating factor, so it is a case of subclinical hypothyroidism. And along with that, when the patient comes with this much high level of TSH, I send the patient for the anti-TPO investigation, which is an confirmatory test for the this Hashimoto's thyroiditis, and it was found that the initial level was 877 with a normal because the normal value is less than 9 and the patient had the value 877. And in that case, I have given the remedy level approach, that is constitutional approach, because the patient has a very she's a very mild character with a lot of emotional suppression, and she has a harassment from her husband. But even after that, she is not responding to the husband, and she is not telling any bad words to the husband, and she is very much very much disturbed with his activities, and she is suppressing all her emotions while considering all these mental faculties and mental symptoms. I have given Staphysagrina 1 with initial doses, and you can see the result. After that, the TSH has reduced to 9.3 and anti-TPO was also reducing. Anti-TPO was reduced, and after that, towards the end of the treatment, she has stopped the treatment. And here the result is that this anti-TPO also reducing and TSH also come to the normal level. So it is a case of Hashimoto's thyroiditis where we got the result with our constitutional medicine. Next, let's discuss about the Hashimoto's disease. Hashimoto's disease, it is considered as one of the most important cause of hypothyroidism with an autoimmune base, because autoimmunity is increasing in it is increasing like anything. That is, it is the current fashion, current era, because of our lifestyle and also because of the stress. It is increasing like anything, and the main symptoms we can see in autoimmune thyroiditis or this Hashimoto's disease are this memory lapse or depression, pale dry skin, a goiter or puffy face, brittle nails, hair loss, and there is an excessive or prolonged menstrual bleeding, joint pain and stiffness, muscle aches, constipation, weakness, tenderness, and stiffness. Why I'm telling these symptoms? Because these are the common symptoms of thyroid disorders. Because the importance of this symptom is that the patient may present with these symptoms, but once you this when you tell the patient for the thyroid serological test, there may be a normal value of TSH, T3, T4, and all the serological tests will be normal with only a rise value of anti-TPO. So once you get these symptoms, we can send the patient for the both serological test and also for the antibody test. Because the relevance of this antibody test is that when anti-TPO is positive, there is a chance of future hypothyroidism. When you get a high level of antibody in the patient investigation, then you can check the process of future hypothyroidism by giving our medicine. So once you get the results and once you get these symptoms, it is important to send the patients for the anti-TPO also along with the serological test. Then what are the common causes of Hashimoto's thyroiditis? We already discussed what is the importance of iodine in hypothyroidism. Here, the importance of this iodine is the excessive iodination, because the excessive iodination will lead to autoimmunity of the thyroid gland and will cause the destruction of the thyroid gland. Because this excessive iodine, this cause is also important while we are considering the management of thyroid gland. Because if the patient has diagnosed with Hashimoto's thyroiditis, you have to advise the patient to limit the use of iodine intake, because it will cause the further destruction of the thyroid gland. And another important cause of Hashimoto's disease is the infections like hepatitis C and viral infection. Have one patient who had Hashimoto's thyroiditis along with hepatitis B. And hepatitis B and hepatitis C, it can also cause a there's a risk of future Hashimoto's disease for that patients. So when you get that patients, you can when the patient is coming to you for the treatment of hepatitis B or C along with those symptoms, then you have to exclude this Hashimoto's disease also. Then stress, we have to stress that stress. Why? Because this stress is the most important environmental factor that can lead to Hashimoto's disease. Because as it is an autoimmune disease, the mental faculties and emotional causes also to be encountered while you're treating this Hashimoto's disease or any other autoimmune disorders. So stress is also an important environmental factor. Then certain drugs like interferons, pollutants, chemicals, etc. And these interferons are the drugs we are using for the chronic hepatitis cases. And pollutants and chemicals, of course, we are all exposed to pollutants and chemicals, and that will also lead to this Hashimoto's thyroiditis. Then what are the presentations of this Hashimoto's thyroiditis? It can also present as euthyroidism. As already told, the serological value all will be normal, and patient will present with these symptoms only. So you have to go for this anti-TPO level. And once you got this, already told, once you got this, you have to treat for this anti-TPO level, because it can lead to future hypothyroid state and future complications. So you have to treat with our medicine. And the next is subclinical hypothyroidism and goiter. It is another manifestation of Hashimoto's disease. And then primary thyroid failure. It is the end stage. That is, the thyroid hormone is not producing any of its hormone, and it will lead to the thyroid failure. And then hypothyroidism and adolescent goiter. Adolescent goiter means a girl with 13 to 19 years is presenting with a simple enlargement of gland. In that case also, you have to suspect this Hashimoto's thyroiditis. The last one is the painless or silent thyroiditis. That is, there is no problem. There may be a slight enlargement in the gland only. When you go for USG thyroid, you will get some thyroiditis, features suggestive of thyroiditis. This will be the impression. In that case also, you have to exclude the Hashimoto's thyroiditis by doing this antibody test. Then let's see another case. you can see this values, that is TSH value was initially 43 and anti-thyroid peroxidase antibody or anti-TPO was initially 66, that is above its normal level. So it's a there here it is a high level of TSH along with the positive anti-TPO value. So it is a second presentation of what we have told earlier of Hashimoto's thyroiditis, that subclinical hypothyroidism along with goiter and with the presence of antibody, that is anti-TPO. And the silent thyroiditis, here you can see the dimensions of lobes are within normal limit with only features of thyroiditis. That is, features of thyroiditis means there will be increased vascularity and there's a features of inflammation, etc. So it's a confirmed case of Hashimoto's thyroiditis. Here also we have given, I have given that this constitutional approach as Natamore 1 was given as constitutionally by considering the mental and physical symptoms of the patient, and after that the result came to TSH become normal and TPO also become normal within normal limit, that is less than 34 is the normal limit. Here it came to 24. So it is a pure case of Hashimoto's thyroiditis. It's a treatment protocol developed by Dr. S.G. Biju and is clinically verified by many doctors and was found very effective in treating this hypothyroidism and Hashimoto's thyroiditis. As discusses, in the first month, when a patient comes to you with a result of hypothyroidism, in the first month we can give Natamore 30 BD. BD means 2 times daily, twice daily, along with pituitrinum 30 BD. We can give it in the first month. On second month, if you are not getting the result, you can give hypothalamus 200 2 dose. And in this, usually a simple case of hypothyroidism will resolve by first 2-3 months of our treatment. If it is not resolving or if it is not responding to the treatment, on the second month onward, you have to send the patient for the anti-TPO test, that is the antibody test. If you are getting the anti-TPO test negative, that is it is confirmed it is a case of hypothyroidism only. On the third month, you should start the constitutional prescription, that is based on the this emotional and mental, that is we know that is constitutional prescription of the prescription along with thyroidinum 3x, and that is an organ remedy can be given along with our constitutional medicine BD, that is twice daily. And on the fourth month, you should increase the potency of remedy along with Spongia 30 TDS. And on the fifth month, we can also give fucus tincture 6 drops morning and iodine 3x TDS along with hypothalamus 200 OD, that is once daily. This is the protocol of hypothyroidism, treatment protocol of hypothyroidism. And if you got a positive anti-TPO result, it is a confirmed case of Hashimoto's thyroiditis. In that case, if it is a Hashimoto's disease, on the third month, on the first 2 months, we have given the Natamore, pituitrinum and hypothalamus. And on the third month onward, if it is Hashimoto's disease, we can give Sepiavanam weekly with Ambragracia 30 BD. Sepia and Ambragracia you may connect because it is both belongs to fish group of remedy, that is animal kingdom under fish group of remedy. So it is found to be very effective in treating Hashimoto's disease and autoimmune thyroiditis. So you can try these 2 medicines, Sepiavanam along with Ambragracia 30. On the fourth month, as an indecurrent, you can also give Medorinum 10 once in 15 days with the Spongia 30 TDS. And on the last month, we can give Carcinosin 200 weekly. This is a very effective protocol developed by Dr. S.G. Biju. You can try this. Next, the most important thing, that is when in our clinic we have come across many of the thyroid USG report. But we have to identify what are the things in that USG report. We usually go through the impressions only. Last one, what they are writing as an impression is a case of thyroiditis or like that. But we have to know each and every terminology is used by those doctors. Then only we can assess the prognosis of the patient by considering this USG. Then what are the indications of USG? When you have to send the patient for a USG, when you are suspecting a nodule, that is when on the investigation, on the examination of the patient, you are suspecting a nodule in the thyroid gland, you can send them for USG. Then cervical mass, it can be an enlarged lymph node or it can be a nodule. So if you have if you found a cervical mass, you can send for USG. Then post OP residue, because the patient has undergone a near total thyroidectomy or subtotal thyroidectomy, then what portion of gland is left in their body. So in order to understand that, we have to send them for USG. Then diffuse changes, we have seen a enlarged nodule or enlarged thyroid gland, then you have to send this patient for the diffuse this USG. And another important thing, when you are suspecting a patient, or patient has a strong family history of thyroid cancer or any other cancer, especially MEN2. MEN2 is multiple endocrine neoplasia type 2. In that, there is a combined neoplasm of thyroid, parathyroid, and adrenal glands. In that cases, medullary carcinoma of thyroid is more prominent. So in that cases also, in order to exclude the family this chance of malignancy, you have to send the patient for the USG. It can also use as a prognosis also. Then, what's the this dimensions we are getting in the normal anatomy of USG? That is, in this we have you can memorize like 2, 4, and 6. That is the order of even numbers. In this, the AP diameter, the log dimension, the AP diameter is 2 centimeter and its length is between 4 to 6 centimeter. It is a normal dimension of thyroid gland, and the normal dimension is important because we have to compare it with the result of the patient. When it is exceeding the normal dimension, it means thyromegaly. Then this isthmus isthmus is 0.5 centimeter. That is, normally it is 4 millimeter to 5 millimeter in size. When there is a decrease, there is a size increase in the size of isthmus, it will produce a central midline swelling of the thyroid gland. And adult thyroid volume, it is between adult thyroid volume, it is between 10 to 15 cc. That is, volume is 10 to 15 cc means if it is exceeding the normal volume, it is also a feature of thyromegaly. So you have to consider the dimensions. Anterior posterior diameter is 2 centimeter and this length is 4 to 6 centimeter and its normal volume is 10 to 15 cc. Okay, you want it in slow, okay. Make it slow, sorry. This is very important, doctors, because when you are coming, when a patient is coming with this USG thyroid, these are the common terminologies. We may be confused or we may be unaware of, and we tell that it's okay, it's no problem like that. But we have to be careful with these terminologies when by looking this USG thyroid. The first one is hyperechoic nodule. Hyperechoic nodule means when we all know this USG is done by passing this ultrasound through the gland. Where we are examining, it is passing through the gland. When hyperechoic means it is re-emitting all the ultrasound passing through the gland. That means it is hyperechoic. It is commonly found in cystic nodule because this nodule is fluid filled. So it is known as hyperechoic nodule. It is not this fluid filled colloid, and that colloid or fluid filled nodules are known as hyperechoic nodule. The next term is isoechoic nodule. Isoechoic nodule means there is lack of contrast. Commonly, there may be a difference in contrast between the nodule and the normal thyroid parenchyma. But in some cases, there is a lack of contrast between the nodule and parenchyma. It is known as isoechoic nodule. The next is hypoechoic nodule. Hypoechoic means it is absorbing all the ultrasound passing through the hypoechoic nodule means it is absorbing all the ultrasound passing through the nodule. So it is there is nothing to re-emit back. It is absorbing all the ultrasounds. It is known as hypoechoic nodule. It is normally solid nodule, and when you saw this terminology, you have to be careful while saying this hypoechoic nodule. You have to be careful. Please note this. I will explain it later. And the next one is the spongiform nodule. Spongiform nodule means it is otherwise known as honeycomb nodule. Honeycomb nodule means we can say that this honeycomb is it's a combination of both solid and fluid filled. That is partially it may be hypoechoic and partially it's hyperechoic. It comes in between the hyperechoic and hypoechoic nodule. The next one is degenerating nodule. Degenerating, as the name indicates, it is degenerating. It undergoes the process of degeneration. Why it happens? Because there is inside the thyroid gland there is a lack of blood supply and will undergo the process of degeneration. It can be considered as a benign also because it can regress the size normally even we are not giving any treatment. So it is known as degenerating nodule. The next thing also we have to be very careful while saying this terminology, microcalcification. It means a small spicules-like calcification is seen inside the thyroid gland. The size of microcalcification, when you have to say this, it is microcalcification. The size should be less than 1 millimeter. Should be less than 1 millimeter. Then only you can say it's a thing of microcalcification. If it exceeds 1 millimeter, that is 1.2, 1.4 like that, it is a macrocalcification. It is not a dangerous thing. But once you have seen microcalcification in USG thyroid, it may be a chance of malignancy is there. So it is also very important term while considering the prognosis. Microcalcification, hypoechoic nodules. And the next one is intranodal vascularity. The name itself, it explains everything. Intranodal vascularity. Inside the node, there is an increased vascularity. So there's a chance of increase in size of these nodules in the near future itself. So you have to cut short this rate of enlargement of this thyroid nodule. Otherwise, it can change to a malignant one. So these are the common terminologies we came across while we are examining a USG thyroid case. Hyperechoic nodule, hypoechoic nodule, isoechoic nodule, spongiform nodule, degenerating nodule, microcalcification, and intranodal vascularity. Another important thing you have to consider while examining a USG thyroid is the Thyroid's criteria. Thyroid's criteria is very important. When you are sending a patient for USG thyroid, you have to specify in your investigation request, you have to specify that please specify Thyroid's. Then only they will sometimes they specify the Thyroid's, because the Thyroid's criteria is very useful for assessing the prognosis of the patient in the follow-up. So when you are suspecting a nodule, it is mainly associated with nodular type of thyroid disorders. When you are suspecting a nodule, or you have already seen some nodules in the previous report, for the next investigation, when you send the patient for the next investigation, you should please specify the Thyroid's criteria. Then only they sometimes specify. In that, they will consider the composition, echogenicity, shape, margin, etc. In that, the composition we have already discussed, that is hyperechoic, hypoechoic, like that. In the hyperechoic means it is a cystic nodule, and hypoechoic means it is a solid nodule. It can be spongiform nodule also. That's a combination of hypoechoic and hyperechoic. Like that, they will give some points, and will at last they will add all the points and will categorize into Thyroid's 1, 2, 3, like that. In echogenicity, already told that is hypoanechoic, like that. Then shape it is very important. When you are inspecting or when you are palpating a thyroid gland during an examination, if you found it is a wider, that is it is the anterior, the transverse diameter is more, then it is a safe side. There is no problem. When you encounter a taller nodule instead of a wider nodule, you should be suspicious, because there is a chance of future chance of malignancy is there for the taller nodules in compared to the wider nodules. Then margins. Margin means a smooth margin, a capsule. Smooth margin means it is capsulated, it is well defined. So it can be a benign nodule. But once it changes to an lobulated or irregular, like that, or extra capsular spread, etc., that will lead to a malignant chance is more. So margin is also important. The next thing is the calcification. We already discussed if it is macro calcification, that is greater than 1 millimeter, it can be considered as benign. It is a calcified nodule. It may be a calcified nodule, which may be benign. But if it is a micro calcification, which was not found in the earlier report, but now it appeared as a micro calcification, you have to be careful. It can be an ongoing process of malignancy. So these things they are considering when classifying in the Thyroid's criteria. In Thyroids, there are mainly 5 classifications. That is Thyroids 1, 2, 3, 4, and 5. If Thyroids 1 and 2, it can be a safer sign. It can be a benign nodule only. Thyroids 3 onwards, you have to be suspicious. In case of Hashimoto's thyroiditis, usually it comes under Thyroids 3 criteria. So Thyroids 3, it may be Hashimoto may not be any malignant disease. It can be benign also. So then 3 onwards, we have to be careful. When Hashimoto's disease is associated with any nodule, the size of the nodule should be. We have to be assess the size of the nodule also. When the patient, you can see, I think it is legible. You can see that in Thyroids 3 criteria, if it is the nodule size of the nodule is exceeding 1.5 centimeter, you have to do the follow-up investigation. When you should do the follow-up investigation, you can do a frequency of 2-3 months. That is, after 3 months, you have to investigate or reinvestigate the patient with the USG thyroid if it is exceeding 1.5 centimeter. If it is exceeding 2.5 centimeter from Thyroids 3 onwards, if it is 2.5 centimeter or more, then they are suggesting that is the need of FNAC, and that is biopsy is suggesting. Then next is the Thyroids 4 criteria. Thyroids 4 means it is moderately suspicious. That is here when in Thyroids 3, if 2.5 centimeter is the safer limit, when it comes to Thyroids 4 criteria, 1.5 centimeter itself is a suspicious limit. So when this Thyroids criteria is ascending, that is from 3 through 4 to 5, this size of the nodule, even 1 centimeter or 0.5 centimeter becomes suspicious. So we have to be careful with the size of the thyroid nodule. There you can see what is the chance of malignancy in each case of Thyroids criteria. In Thyroids 1, already told it's a normal nodule. There may be no nodule, or there may be single enlargement. And there's a simple enlargement of thyroid gland only. Then Thyroids 2 also it is a benign, and here we can see that term hyperechoic because it is a purely cystic nodule. That here comes the term hyperechoic nodule. Here also the chance of malignancy is 0. It can be the spongiform nodule also. Spongiform and hyperechoic, now you may understand it comes under benign category. It is not that much suspicious. And the Thyroids 3, it comes under low risk category. Low risk means it can be an isoechoic or hyperechoic, and there is no feature of high suspicion, but here the chance of malignancy starts. It is only little chance, that is 2 to 4%. And Thyroids 4, it is an intermediate risk. There is a here starts the feature of hypoechoic. That is the solid nodules starts to appearing. And here the no feature of high suspicion, but here the chance of malignancy is 6 to 17%. And Thyroids 5, it is high risk category. Here the size of nodule even less than 0.5 centimeter is also suspicious. So you have to be careful. While you are getting this Thyroids 5 criteria, you can send the patient for the FNAC for rule out the chance of malignancy, or if it is a confirmed case of malignancy, you can send the patient for the thyroidectomy and all. In that cases, you may got the use features like irregular shape, irregular margin, microcalcification, not that microcalcification, and marked hypoechogenicity. Hypoechogenicity means it is a purely solid. It converted into a purely solid nodule, and here the chance of malignancy is 26 to 87%. That's a high risk category. There's a chance of malignancy is very high. So again, I'm telling you, please, when you are sending the patient for this USG, please do specify Thyroids criteria. Then In thyroid USG, you may see some impressions, isn't it? Towards the last towards the last of the report, you may see some impressions. When you are saying these terms in the impressions like colloid nodule, hyperplastic nodule, follicular adenoma, non-toxic or toxic nodular goiter, and thyroiditis with query Hashimoto's thyroiditis, these all are suggestive of benign nodules. So you can take the case. There is no risk of malignancy. You can definitely take the case. But when you have seen these terminologies like papillary thyroid carcinoma, as the name indicates, carcinoma, this follicular thyroid carcinoma, medullary thyroid carcinoma, anaplastic carcinoma, lymphoma, and other cancers or mets. And here, the only confusing term is lymphoma. In all other terms, carcinoma is itself is there, because in these cases you have to be careful. You can send the patient for the further investigation or for the surgery. Then the next investigation is histology. Histology, the mainly two things are doing for histological analysis. First one is the fine needle aspiration cytology or biopsy, or FNAC or FNAB. Or next one is the biopsy or excisional biopsy. Excisional biopsy is usually done after surgery, after you send the specimen for the biopsy report and the cytological report. And FNAC or FNAB you can do in the live tissue, that is before surgery also we can do. It can be a USG guided or otherwise also. Then, like what we are telling in the TERADS in case of USG thyroid, the criteria they are using in FNAC is Bethesda criteria. Usually we are not sending patient for FNAC, because once we have sent the patient for FNAC, especially in case of multinodular gout and all, the patient will be resistant to the treatment, will not get the result after by giving our medicine. If once we are sending this patient for FNAC, these are the experience a lot of doctors are sharing. So usually we are not sending patients for FNAC, but once when they are coming with an FNAC report, we should assess what is the condition. So that is why we are discussing here. First one is the Bethesda class. Mainly 6 categories are there. The first one is non-diagnostic or undiagnostic. Non-diagnostic or undiagnostic means here what happened is they are taking the specimen, but they didn't get enough cells for diagnosing the condition. It is the non-diagnostic category. Here also the risk of malignancy is there, because it doesn't mean that they have explored the malignancy. They didn't get the specimen to include to assess whether there is a malignancy or not. So the risk of malignancy is 1 to 4%. So what will they do? They will repeat the FNAC with an ultrasound guidance. This is their management. So the second category is benign. Benign means the risk of malignancy is 0 to 3. Here they got the cells and they confirm it is a benign case. So here we can do clinical follow-up by assessing this serology and all. The next thing is atypia or undetermined significance, or follicular lesion of undetermined significance. And here also it is a third category. Risk of malignancy is, you can see it is increasing one after another. It is 5 to 15%. Here also we have to repeat the FNA. The next is follicular neoplasm or suspicious follicular neoplasm. Follicular cells, one thing I have to say is follicular. When you have seen follicular cells in case of IOSG or FNAC result, it is difficult to differentiate between follicular adenoma, it is a benign condition, and follicular carcinoma, which is a malignant condition. It is difficult to differentiate between follicular adenoma and carcinoma using an FNAC report. So they are using the confirmatory diagnosis for follicular adenoma and carcinoma is the excisional biopsy. It is it's an unfortunate thing. Maybe it may be an follicular adenoma, benign condition only, but patient may have undergo an unnecessary thyroidectomy for this condition and will later diagnose as follicular adenoma only. But it is a drawback of FNAC. You can't differentiate between follicular adenoma and carcinoma by using single FNAC. This confirmatory test is excisional biopsy. So that is why the usual management is surgical lobectomy. Once you get the follicular cells, they will rapidly undergo the surgical lobectomy. And the next thing is suspicious for malignancy. That is a fifth category. That chance of malignancy 60 to 75%. Here also they will suggest for near total thyroidectomy. That is surgical removal of the thyroid gland. And the last one is the uh, malignant. That is a 97 to 99 percentage. It's a confirmatory case of malignancy. So there is a near total thyroidectomy is done. So by this category, you have to be we should know at least patient when coming with this result, we should know what is the level of what is the current status of the patient and how they will go the prognosis. Next important thing, these things we may see in USG report, we can see in USG report and also in the FNEC report. It is very important while you are seeing this report and while you are getting these terms, it is important to categorize the condition. It is they may give only query or other times they in the impression they will give only these terminologies. That is hyperplastic epithelium. If you got this terminology in the impression, and if they are not told, if they didn't tell the condition, then you have to consider these conditions. That is, it may be a case of Graves' disease, hyperplastic epithelium. It may be a condition of Graves' disease, or otherwise it may be due to iodine deficiency, or otherwise it is due to the goitrogen, the use of goitrogens by the patients, or by the PTU effect. PTU is an anti-thyroid drug. It is normally used for the this treatment of hyperthyroidism. That is anti-thyroid against thyroid they are using for reducing the level of thyroid hormones. So if you saw this terminology, hyperplastic epithelium, you have to differentiate these three conditions: and Graves' disease, iodine deficiency, goitrogen or PTU effect. The next is colloid field. If you see this term, colloid field, it may be a idiopathic nodular colloid. Idiopathic nodular colloid goiter, it is a benign condition. Then anaplastic cells. Beware when you saw this term, anaplastic cells, it is a short malignant case. So you have to refer the patient for the further surgical or like that, any other treatment, chemotherapy, radiotherapy, etc. Then lymphocytes. Lymphocytes, it is commonly seen in the condition like Hashimoto's thyroiditis. Why? Because Hashimoto's disease is otherwise known as lymphocytic thyroiditis. That is why you can see lymphocytes in case of Hashimoto's disease. Next one is foreign body granuloma. Foreign body granuloma, if you saw this this term, it means it is a case of de Quervain's disease. What is de Quervain's disease? It is a condition of subacute thyroiditis where it is an acute presentation. You can see after an infection of viral, that is viral infection, the patient is presenting with a painful enlargement of thyroid gland along with there's a difficulty in swallowing. Like that acute presentation patient will present, and if you send the patient for the FNEC or USG or FNEC, you can say this terminology, that is foreign body granuloma. Then you can confirm it is a case of de Quervain's disease. It's a totally benign condition. We can easily manage with our medicine. That will tell earlier, tell later. The last one is the fibrous tissue. Fibrous tissue means it is a case of renal thyroiditis, where the thyroid gland is completely replaced by fibrous tissue. And you can, when you palpate the gland, you can feel a hard mass of thyroid gland because of the replacement of normal thyroid parenchyma with the this fibrous tissue. So these are the common terms we can see in the impressions of the USG thyroid and the histological report. With that terms also we can differentiate the conditions if you know these terminologies. Next. So in our clinical practice, we are discussing it in the this priority order. First one is the hypothyroidism. This is the most common condition we are encountering in our clinical practice. Then comes the Hashimoto's thyroiditis, which is the most common cause of hypothyroidism. And next, it is rare, but it can also come to our clinic. That is hyperthyroidism. It is we all know, we have already discussed what are the types of hyperthyroidism, like subclinical hyperthyroidism, central hypothyroidism, hyperthyroidism, T3 toxicosis, etc. It is an excessive production of thyroid hormone, which can lead to hyperthyroidism. The causes of hyperthyroidism, it is mainly divided into two. That is primary hyperthyroidism and secondary hyperthyroidism. Primary hyperthyroidism means it is a defect in the gland itself. That is, the gland is the culprit and it is producing more thyroid hormone. What are the conditions that can lead to primary hyperthyroidism? First one is Graves' disease. It is an autoimmune thyroiditis that comes under autoimmune thyroiditis, autoimmune hyperthyroidism. The second one is thyroid adenoma. Here there is a nodule in the thyroid gland. It is a toxic nodule. Why it is known as toxic nodule? The nodule is secreting more thyroid hormone. That is why it is known as toxic nodule. So that comes under thyroid adenoma. Then subacute thyroiditis. We already discussed in the earlier slide. That is the de Quervain's disease. De Quervain's disease means it is an acute presentation of the gland of thyroid gland after the viral disorders. The next is excessive intake of iodine. Excessive intake of iodine, what we told, we already discussed this condition under Hashimoto's thyroiditis. In that, a clinical presentation can occur which is known as hashimotoxicosis. What hashimotoxicosis? Here there is an excessive destruction of the thyroid gland which will lead to this release of stored thyroid hormone into the blood, which will lead to hyperthyroid state. It is known as hashimotoxicosis. It is because of the increased destruction of the thyroid gland due to increased antibody that will lead to a short period of hyperthyroidism in the Hashimoto's disease itself. Hashimoto's disease we already discussed. It comes under hypothyroidism, but it can also present with a swinging phase of hyper to hypothyroidism. Here, the cause is due to the excessive destruction of the thyroid gland due to increased antibody production. In that phase, it will show a symptom of hyperthyroidism. So you have to be careful while treating the case of Hashimoto's thyroiditis. The last cause is excessive intake of exogenous thyroid hormone. This thing we can frequently encounter in our clinical practice, because the patient once diagnosed as hypothyroidism and they will go to some physician and they will give some synthetic thyroid hormone supplement, and once they started this synthetic thyroid hormone supplement, you have to assess this hormone level once in 3 months or 6 months, etc. Then only you can regulate this dose of this thyroid hormone by assessing the TSH level. But once the patient started to take the medicine, they will continue this, they will take a prolonged use of this medicine. That will lead to hyperthyroid state, which is it is induced, that is iatrogenic hyperthyroid state. It can also lead to this hyperthyroidism. These are the primary causes of hyperthyroidism, and the secondary is it is not in the gland, it is in the somewhere in the central system, that is either in the hypothalamus or in the pituitary. What has happened in the hypothalamus? Hypothalamus, it can be due to hypothalamic tumor, which is secreting more level of TRH, that is thyroid releasing hormone, or it can be due to an anterior pituitary adenoma or tumor which is producing more level of TSH. Though in turn, this stimulating this thyroid gland to produce more thyroid hormone. So these are the main causes of hyperthyroidism. Then let's see case of hyperthyroidism. Here you can see the level of T3 is, the normal value is 206. Another thing I have to say is when you are assessing a report, you have to just compare it with the reference value of that laboratory itself, because there may be some difference in the reagents using in different laboratories. So it is better to you can compare it with the reference value of that laboratory itself. So here given the normal value of T3 is given as up to 206. Here it is 293. So it is an increased level of T3 level, and T4 level is it is given as 14 as normal level, and here it is the value of patient is 14.26, and TSH value, it is, we all know here the value is 0.005. It is below the normal level. So there is a decrease in TSH with a raised value of T3 and T4. So hope all of you understood the condition. It is a case of clinical hyperthyroidism. That is primary hyperthyroidism, and also it is a clinical hyperthyroidism. So difference in the T3, and there is a high level of T3 and T4 along with decreased level of TSH. And another report, I can see on the right side, there is a raised level of free T3 and T4 also. Here is it is a complete, it is a complete investigation of serological panel, that is T3, T4, TSH with free T3 and T4. There is a raised value of free T3 and T4 also. So it's a diagnostic case of clinical hyperthyroidism, that is the primary hyperthyroidism. Here, when the patient came to me with this report, I have sent the patient for another investigation. That is the anti-TPO level. Why I have sent the patient for anti-TPO level? Because in order to exclude, here I already told there is an increased chance of autoimmune disorders are always there in the patient. So once you got this serological value, the patient financial status agree, you have to exclude an antibody, that is an autoimmunity in the background. Here, the correct investigation in order to rule out the Graves' disease. Graves' disease is the autoimmune variety of hyperthyroidism. Exact this investigation is anti-TSH receptor antibody. I will tell later. It is anti-TSH receptor antibody. But here, patient and it costs around in Kerala it costs around 3,000 rupees. But patient can't afford that much rate. So I send the patient for the anti-TPO level, anti-TPO assessment, because if it is a case of autoimmune thyroiditis or Graves' disease or Hashimoto's disease, there may be a presence of all the antibodies. There can be the prevalence chances are less, but there can be a presence of other antibodies also. In order to exclude this autoimmune background, I have sent the patient for anti-TPO antibody, but it was normal. So it is a case of hyperthyroidism only. Here also, a constitutional approach was given. The medicine, while considering the patient, constitutionally considering the patient, have given Natromor 1M. It was not clear. Natromor 1M was given. Initial dose also Natromor 1M. Then after about 6 months, we got a normal result with free normal T3, T4, TSH, with normal free T3 and T4. That is once it is a now I could say we got a normal result. But when you can say it is a cured case of hyperthyroidism, you have to repeat the investigation after 3 months. You have to stop the medications, even including placebos. You have to stop the medication. Then you have to send the patient for the repeated investigation for once in 3 months in the first 1 year and once in 6 months in the next year, that is in the second year. Then only you can say it is a case of cured hyperthyroidism. So I have sent the patient, I have advised the patient to repeat the investigation for once in 3 months in the next 3 months interval, and they have I have seen three results with 2 months interval, 3 months interval with normal. So I can say it's a case of cured case of hyperthyroidism. So here it is another protocol developed by our mentor, Dr. S.G. Biju, and he is using. It is also a very effective, clinically verified protocol. And in case of hyperthyroidism, commonly using medicines are in the first month you can use RSAR 1M weekly dose along with iodine 3x BD, that is twice daily. And on the second month onward, first see it is a protocol, so it will be easy for you to follow. In the first month you are using this protocol only. In the second month onward or third month onward, we are using this constitutional medicine. But if you can give this constitutional medicine in the first month itself, that's well and good. If you can not doing that, you can follow this protocol. In the second month, you can use this constitutional medicine weekly dose along with thyroidum 3x, that is our organ remedy, along with lycopus tincture 8 drops BD. And on the third month you can use thyroidinum 30 BD along with lycopus tincture. You can increase the dose from 8 drops to 20 drops BD. And on the fourth month it is Spongia 30 TDS. And And he's telling that after fourth month, if you are not getting the result, you have to refer the patient, because hyperthyroidism, as we all know, while comparing to hypothyroidism, it is more dangerous. It is graver condition because it is affecting the cardiovascular system and all the systems of our body, and can lead to thyroid storm. What I have told earlier, it is a very grave condition which can even cause to death of the patient. So hypothyroidism is very it is somewhat difficult to manage as compared to hypothyroidism, but once you got the result, it is well and good. Next, we can tell about some advanced investigation. So, as we are all homeopaths, we have to do some investigations. Not only the investigation, we have to do some advanced investigation also, because we are competing. We are competing with other system of medicine, so we should be thorough with the investigations, and we should be well versed with our equipments, that is medicine, for those conditions also. So don't hesitate to do the advanced investigations also. The first one, the most important, we have discussed it many times earlier, that is anti-TPO or anti-microsomal antibody. It is a confirmatory test for Hashimoto's thyroiditis, that is an autoimmune hypothyroidism. It is positive in about 90% cases of Hashimoto's disease. The second antibody is anti-thyroglobulin antibody. What is anti-thyroglobulin antibody? It is very important. It is positive in Hashimoto's thyroiditis, and also it can be used as a tumor marker. What is tumor marker? It can be it can predict the future chance of malignancy. If it is increasing even after treatment, if it is increasing, then you have to be careful. That is, there is a chance of malignancy is there. If so, it can exclude this chance of malignancy by doing this antibody test. And another important thing I have to tell, that in some cases of Hashimoto's thyroiditis, there may be a negative value of anti-TPO with a raised level of anti-thyroglobulin antibody. You have to be very careful. It is simple case of Hashimoto's thyroiditis, but you may not get this anti-TPO value positive, but there may be a presence of anti-thyroglobulin antibody only. So that is also a case of Hashimoto's thyroiditis with a different manifestation. Then third one is TSH receptor antibody. We have already seen this investigation. I already told about this investigation while discussing about the hyperthyroidism case, because it is a sure shot, and that is, it is a confirmatory test for Graves' disease, anti-TSH receptor antibody. The next one is prolactin. How prolactin came here is an advanced investigation, because in case of thyroid disorders, we may have heard that in case of infertility, one of the most important cause of infertility is thyroid disorders. So what is the cause of infertility in thyroid disorder? It may be due to hyperprolactinemia. There is an increased level of prolactin in the body will lead to this infertility. So if a patient is presenting with infertility, you can also send the patient for the checking the level of prolactin. I had two cases with secondary infertility along with Hashimoto's thyroiditis. Both of that got result. That is, both of them got conceived, but I haven't sent the patient for the prolactin level. If I have sent, it may be more evidence based. So once you got such a case with an infertility along with Hashimoto's disease or any other thyroid disorder, you have to send the patient for that is prolactin level. It may be due to hyperprolactinemia. Then calcitonin. Calcitonin is another tumor marker which is presenting in medullary thyroid, and that is medullary carcinoma of thyroid. The next one is vitamin D. Vitamin D is also, it comes under advanced investigation in case of Hashimoto's thyroiditis. Because in case of Hashimoto's thyroiditis, patient may be presenting with crumbled teeth, or there is calcium, there is defects that is more related to calcium metabolism. There is pain in joints, pain in bone with crumbled teeth, like that, etc. Then if these patients are presenting with these complaints, then you have to send the patient for vitamin D also. Then next one is anemia. Anemia is also you have to exclude. We have seen many cases with hypothyroidism along with anemia. Why this happened? Because HB, that is production of hemoglobin, is mainly it is controlled by our thyroid hormone. When there is a reduction in thyroid hormone, there will be consequently there will be reduction in the this hemoglobin. And other autoimmune disorder that also you have to exclude. That is, in one of my case, she was diagnosed as a Hashimoto's thyroiditis case after under my treatment. Once she has approached me as a case of hypothyroidism, has sent for anti-TB. It was found positive, so it is a Hashimoto's thyroiditis. By under my treatment, she has one day she has got suddenly with febrile, that's fever, and a lot of acute complaints were there, and with a low level of platelet count, like that manifestations were there. But it was a case of SLE. When I sent the patient for anti-DS DNA, it was found that positive. So there's a chance of other autoimmune disorders along with your Hashimoto's or Graves' disease are more. So once your patient is presented with such and such complaint, you have to exclude that also. So let us discuss the management. These things I have already told in all the cases I have shown here. I have given the constitutional medicine. If we have not able to give the constitutional medicine, or once it may be, or sometimes it may be difficult to get all the symptoms of the patient. These are the cases where I have got the most symptoms of the patient, so I could able to give the constitutional medicine. Or once if it is difficult to get all the symptoms, or if you are difficult to give the constitutional medicine, we can try these medicines and these drugs and medicines in order to alleviate the complaints of the patient. But it is not the end of the treatment, or it may not always give the cure to the symptoms. So always give importance to constitutional medicine. Along with that, you can also use these drugs. The first one is high TSH. High TSH means it is that when you are getting a case of hypothyroidism or Hashimoto's disease, but the patient once you may have seen in the initial case, then the first case, the level of TSH was 150. 150, it is a very high level of TSH. In that case, if the patient is not agreeing, but you are convincing the patient that it is due to the raised level of anti-TPO, like that, if they are not convincing, you have to reduce the TSH rapidly. In that case, we can use these drugs and medicines. First one is Natrimo 200 can be used weekly along with pituitrinum 30 TDS. It is giving very good result. I have used it many times in order to reducing this TSH. And also you can try Spongia 30 TDS or Spongia 200 4 dose. It is giving very good result for reducing the high TSH value. Then the next condition is swelling. That is, we have seen many presentation of Hashimoto's thyroiditis, or other presentations also. There may be a enlargement of gland only. There is swelling only. In that case, you can use Lycopus tincture. Lycopus tincture we already discussed in the protocols. That is, can use 8 drops TDS, or you can also increase the dosage to up to 20 drops TDS. And another thing you can use is Spongia. Spongia, we have already know it is a glandular remedy and will surely reduce the glandular size. And another important drug you can use is calcareous fluor. Calcareous fluor, it is very important. Why? Because it is the only remedy under complete repertory where you get under the rubric thyroiditis, that is external throat inflammation, thyroid gland is the only drug under thyroiditis in the complete repertory. Complete repertory is the only repertory where you get the symptom related to thyroiditis. Other repertories you will get only the symptoms, that is goiter or hypothyroidism, hyperthyroidism, etc. Inflammation, thyroid gland is getting only in that repertory. In that, the only medicine is calcareous fluor. So it is a sure shot you can use in the any potency along with your constitutional medicine. Then the next important drug is for muscle pain. We already told some of the symptomatologies in hypothyroidism and also in Hashimoto's disease. Patient may present with muscle aches. In that case, you can use Fucus tincture. Fucus tincture, you can drop 8 drops TDS along with your constitutional medicine. Then you found only nodules. You found on examination, you found some nodules in the thyroid gland, and you sent the patient for USG, and you found only nodules, but there is no defect in this there's no serological deviations, then you can use these drugs like scrofularia tincture, conium. Scrofularia tincture, the dose is same, that is 8 drops or up to 10 drops TDS, with conium 30 BD and Cistus 6. Cistus 6C you can also use, and calcarea iodide. Calcarea iodide, baryta iodide is also there. This the iodine group, all the iodide groups are this Croplos remedies. So you can use calcarea iodide 200, baryta iodide, etc. 200, etc. Or if the patient is presenting with obesity along with hypothyroidism, that is, it is a common presentation, that is obesity and hypothyroidism. They are presenting it conjointly. You can use fucus tincture for the weight reduction. Fucus tincture is also specific for hypothyroidism, but it will help you for reducing the weight. There will be a rapid reduction in the weight. You can use it for the reduction in case of obesity with hypothyroidism. Next is a suspicious nodule. Suspicious nodule, where we have discussed, that is in the TERAS 3, TERAS 4, TERAS 5. These are the suspicious nodule. And in case of suspicious nodule, see, once you have got the report with a hyperechoic nodule or isoechoic nodule, in the next follow-up you see you got it, you got this hyperechoic has converted into hypoechoic, that is become a solid nodule with some sort of microcalcification. So these things are going in the bad side, in the bad prognosis. So these are becoming suspicious nodule. So in order to cut short their progression, that's a conversion of malignant chance, you can reduce this by using this drug, that is carboanimalis 200 BD. You have to repeat this drug up to the next follow-up scan, and you will see that there won't be any further progression. But in order to reverse back this anomaly which is already present, you have to give the other drugs also, like constitutional approach is needed, but you have to cut short. You can further progression can be reduced by using this drug. Next is thyroiditis. Thyroiditis, here specifically it is de Quervain's disease. What I have told earlier, it is a subacute thyroiditis after the viral disorders like that. You can use, it is a sure shot. I have used many times. You can use 4 doses of Hepasar 200. Hepasar 200, 4 doses can be used as BD. Then after that, the swelling and pain will be subsided. The patient is mainly presenting with swelling and pain of the thyroid gland after an acute viral infection. Then in that case, because it has an antiviral and antibacterial property, Hepasar, so it will usually resolve this condition by giving this medicine. And another is a very important tip given by one of our legend, Dr. Ismail Said, and he's told that you can use either in case of hypothyroidism or hyperthyroidism, that is in any thyroid disorder, you can use thyroidinum. It is Hepasar 200 BD, that is 2 times. 4 dose you can use morning and night as 4 dose BD you can use. Then thyroidinum 10 once in 2 months. Once in 2 months you can use as an organ remedy, either in case of hypothyroidism or in case of hyperthyroidism. It will fasten the result. He told that he has an experience that it will fasten the result either in case of in any sort of thyroid disorders. For nodular goiter, it is and the protocol of Dr. S. G. Biju. Sir told that in nodular goiter you can try these things also. I have already told some tinctures like then scrofularia, Cistus 6, this calcarea iodide 200, etc. And he is using graphitis 10 weekly dose along with chromium 30 BD, that is twice daily, then lapis alba 30 and scrofularia tincture. I have to tell one thing about lapis alba. Lapis alba, you may have heard that you can, the common presentation along with hypothyroidism is dyslipidemia. Dyslipidemia, there's a defect, and that is in the lipid metabolism there may be some fault. So it can lead to hypertriglyceridemia, that is triglycerides may be high. In that case also you can use this lapis alba. Lapis alba is very effective for high level of triglycerides along with hypothyroidism. Can you hear me? let's discuss some of the drugs, some of the remedies. That is, in the protocols, I have told that you have to use the constitutional medicine like that. In every case, I have told you have to use the constitutional medicine. Then, what are the common constitutional medicine we got result in case of thyroid disorders or Hashimoto's disease? The most commonly, the common drug is common remedy is sepia in one potency. See, in all case of in many cases of this Hashimoto's disease or anything, if you are taking the symptoms, if you are taking this mental symptoms or physical symptoms of the patient, we can give the medicine as medicine in higher potency, that is 1 potency, or either you can start in 200, or you can ascend the potency. Or if it is a sure shot, you are sure about the result, that is sure about the constitution, you can start with the high potency itself. That is usually start with by 1 potency. You are confident, you can start with the 1 potency. That is about the potency selection. Then the common remedies are sepia 1. Sepia 1, I have got 7 cases with result with sepia 1. And Natrimor 1 is very good, it is very effective. And Staffi 10. Staffi specifying potency is 10 because it has a, that is when you are selecting a staphylococcus constitution, it may be like that what I have told earlier, that is, the patient has a very severe this emotional suppression. They are not expressing their emotions, they are suppressing everything, and in that cases we need to act it on the mental plane. So you have to give it in the 10 potency. This is staphylococcus 10. And then Auromet 1. Where you have to select Auromet 1. I have told 2 cases of infertility with Hashimoto's were there. In that one case got result with Auromet 1. And here, when you are selecting, you have to assess the family background also, or miasmatic background also. If it is a predominantly syphilitic miasm in the background, syphilitic miasm in the background, then you can go for this Auromet 1. And along with that, patient is highly ambitious, like that. What we have got in the Auromet personality, highly ambitious personality, that they will always try hard for achieving their the targets and all. With high syphilitic background, you can try this Auromet 1. And this next is Ambrogenesia 1. Ambrogenesia also we have discussed in the protocol, that is along with sepia 1, you can give this Ambrogenesia 30 BD, and if you got it is a constitutional remedy, you can give it in, try it in 1 potency also. And calcaricum is also very good remedy. If it is presenting with this obesity and more of hypothyroid symptoms like cold intolerance, obesity with that is an inertia type of constitution. You can try this calcaricum. You can ascend the potency from 200 to 1. It is usually I'm doing like that, 200 to 1. Or sure shot, if you can give 1 also, but it is better to ascend the potency from 200 to 1. Then RSALB also you can use it, especially you can use it in the case of Hashimotoxicosis. What I have told earlier, that is the Hashimoto's disease with the presentation of hyperthyroidism. It is already discussed in the protocol of hyperthyroidism. So it is a high risk, it is more of syphilitic remedy. So you can try it in the hyperthyroid phase of Hashimoto's disease. RSAT 200 can be given. And the lycopodium, I didn't specify the potency. Why? Because like that, what I have told earlier, you can ascend the potency from 200 to 1. Lycopodium you can start, can give as a constitutional medicine. Then carcinosin, in all the cases of Hashimoto's thyroiditis, it is better to give an anti-miasmatic remedy as a block remover. It is very, it is almost sure shot. While you are giving an anti-miasmatic nosode as an intercurrent remedy, it will surely fasten the result. You will get the result in a, you will get a reduced value of anti-TPO in the next follow-up investigation itself when you are giving an anti-miasmatic remedy as an intercurrent. Once we are not able to find out the anti-miasmatic remedy, how we are finding the anti-miasmatic remedy? We are assessing the family history of patient, from the past history of the patient, that is past illnesses and the presenting complaints and physical journals of the patient. We are assessing the miasm of the patient. If you are not able to analyze the miasm of the patient, then you can simply give this carcinosin 200 as an intercurrent. It is almost a sure shot in case of Hashimoto's thyroiditis. We can use this carcinosin 200 as an intercurrent. Why? Because this Hashimoto's disease itself comes under psychosyphilitic miasm. It is predominantly syphilitic. It is predominantly syphilitic, but there is some psychotic thing in the background. So you can use this carcinosin 200 as an indicurrent. Please note this point is very important. You can give and you will find the result. It is very important. Carcinosin 200. And another important thing is the pregnancy and thyroid. Pregnancy and thyroid is very important because we all know the normal level of TSH value in the normal adult. But in pregnancy, the value is entirely different. Yet it is the maximum up to 3, and that is international macro international unit per liter. It should be less than 3 because the need of thyroid hormone in the body is more as compared to the normal adult human being. So TSH value in pregnancy, you should be very careful when a patient under your treatment is getting pregnant under your treatment. And in that case, if it is the value is TSH value is 5 or 4, then you should give medicines for reducing it to 2 or 3, etc. It is normal to get a low TSH value in the early stage of pregnancy due to thyroid stimulating effect of HCG. Why this happen? Because when this patient is getting pregnant and when you are getting this towards the hyperthyroidism level of TSH value, it is a normal mechanism. It is because of the effect of HCG on the thyroid gland. So don't worry about that fluctuation. You can continue with your treatment. Then later it may be hypothyroid due to increased demand. It is also another observation we can see when a patient gets pregnant, because there is an increased demand in the body of that female because of the because there is need is increasing in the fetus also. So that time also it is a normal thing. And another thing I have to tell about the management of hypothyroidism in pregnancy. If you are treating a patient with hypothyroidism and she got pregnant, and if you are giving the medicine and the level is between 4 or 5 or like that, if you are giving the medicine, you have to check the this TSH value after 2 weeks. Once you are not getting the TSH value within this normal limit, that is less than 3 or 2.5, you have to tell the patient for taking this artificial thyroid supplement, because it is a very this demand is very high in that stage because of the development of fetus is going on in the initial, especially in the first trimester. It will affect the neuratal development of the fetus. So kindly recommend the patient for taking, don't hesitate the patient for recommending this taking this artificial thyroid hormone supplements. Once after they are taking the medicine, you can taper the medicine after giving our medications also. But once you couldn't achieve that within 2 weeks, you can advise them for taking that. So pregnancy is a stress test for thyroid gland. Always remember that. And next thing is food. Uh, there is always a question that patient will ask when come to us when they are treating for thyroid disorders. The first one is iodine. Already told, if it is a hypothyroidism, it's a simple case of hypothyroidism, we can advise iodine intake. But if it is a case of Hashimoto's thyroiditis, it is better to avoid them to advise them to avoid iodine intake, because iodine toxicity can lead to hyper and this Hashimoto's thyroiditis. Then anatabin supplementation. Anatabin supplementation, it's a later research that is going on under this subject. That is anatabin. It is a chemical that is found in Solanaceae family of vegetables. Not Solanaceae family. That common vegetables that comes under Solanaceae are, we all know, potatoes, and then brinjal, tomatoes, and all. So you can advise the patient for taking this vegetables that will reduce the incidence and the degree of Hashimoto's thyroiditis. Then selenium supplementation is also important. Selenium supplementation, well, because it is an important anti-inflammatory action, so it will reduce the inflammation of our gland. So the important dietary supplements are milk, yogurt, egg, seafood, organ meat, cereals, etc. And vitamin D supplementation, already told in the advanced investigation what's the relevance of vitamin D. And next is gluten. Gluten is also, some patient may have this allergic disorders towards the gluten. So in that case, you can advise them to avoid the gluten intake. Then soya, very important, you have to note this, because it can affect even the synthetic thyroid intake in the thyroid patient, hypothyroid patient. So once they are under our medicine and also taking the synthetic hormone, again they are continuing to take the soya products and all, there won't be any absorption of this synthetic hormones also itself from the body and lead to hypothyroid state. So avoid, tell them to avoid that drugs. Then vegetarian, that soya, and the vegetarian and vegan diet, it is also another ongoing this uh, there is also another ongoing research, that is vegetarians and vegan diet. That is, this non-vegetarian diets are causing unnecessary inflammation of our gut epithelium and will lead to they will cause an increased, that is the aggravation of this ongoing autoimmune process in the body. So it is better to advise them to take the vegetarians and vegan diet. Next important question or doubt that come to our mind is, once the patient is already taking this thyroid supplement, and that is a synthetic thyroid hormone, they are approaching to us and they want to switch over to our system of medicine. Then how we can getting off, or how we can taper those drugs? And mainly it is based on 5 things. First one is the age of the patient. That is, if the patient is in the teenage, that is in 13 to 19 years, that time the metabolism of body is very high, and each and every cell of the body needs the thyroid hormone at its peak level. So in that time, if you are suddenly tapering or suddenly stopping the thyroid hormone supplementation, that will lead to unnecessary complications. So we can slowly taper the thyroid dose, this hormone supplementation. The next one is sex. While considering sex, male and female, the more this demand is more in case of female body. So in case of female also, while you are tapering this thyroid hormone, you have to be very careful and you have to slowly taper this thyroid hormone while considering the symptoms of the patient. And third one is the family status. Family status, what I meant is this is she completed the family or not, or if she is an expectant mother, or she is expecting a future pregnancy, then you should not stop the thyroid hormone supplement at once. You can, after giving your medicine, once it has started action, then you can taper the dose and don't stop it at once. And current dosage is also important. If a patient is taking 100 mg thyronol or thyroid supplement, and 25 mg thyroid supplement is different. If a patient is taking 100 mg, you can taper it like 75, 50, 25, etc. If it's patient is taking 25, maybe you can stop it at once according, while considering the age and sex of the patient. And it is the current dosage is also important for getting off this thyroid drugs. And other comorbidities also, it's very important. If a patient has a thyroid, there's diabetic issues or diabetic complaints, and dyslipidemia, along with this hypothyroidism, there is a future chance of CAD, that is coronary artery disease is there. So once we have stopped the thyroid hormones at once, there may be chance of atherosclerosis. Atherosclerosis is there, so chance of CAD is there. Surely we can stop these medications after giving our medicines, or after we have found that our medicine is acting, but do it steadily, or you do it very slowly. Then, what are the things we have to do in the follow-up? So we have already discussed about what are the medicines we have to be given. That what are the things we have to do in the follow-up? Check the TSH only after 2 weeks after medication or tapering. It is very important this time period, because the action of synthetic thyroid hormone is up to 2 weeks, that is 14 days. It is a half-life of 7 days, but it can last up to 2 weeks. But in some patients, it can last up to 6 weeks. But commonly, it lasts up to 2 weeks. So after tapering the medication, only 2 weeks after, you have to recheck the TSH value. Then after our medication, also you can. It takes about we will get the symptomatic relief within 2-3 days. But the body will start producing thyroid hormone within this 2 weeks. So it is better to reinvestigate the TSH level after 2 weeks of a medication and tapering. And if TSH is decreasing and towards hyperthyroidism, taper the dose. So if a patient came with hypothyroidism, we have given our medicine. Along with that, they are taking the synthetic hormone supplement. On the next follow-up TSH investigation, it was found that it is towards the hyperthyroidism. It means our body start responding to our medicine and it started producing thyroid hormone. So you can reduce the synthetic hormone supplement. If they were using 50 mg, then you can reduce it to 25 mg. Like that, you can taper. And third point is, if TSH increase rapidly, it can be due to a withdrawal of this synthetic supply. That is, and then in some few cases you may see that you have given the medicine and anti-TPO reduced. Anti-TPO reduction means it is sure that the remedy given by you was sure and it is an exactly similar, exact similar one. And if TSH goes high, it means that it may be due to a rapid withdrawal of your synthetic hormone supply. In that case, don't worry, convince the patient that it will come down, or otherwise we can use those drugs that I told earlier, like Natrimor and Pituitrinum, for the rapid reduction of TSH. Then this thing I have already told, that is follow-up investigation after stoppage of medication, once in 3 months for first 1 year and once in 6 months in the next 1 year. That is, it is not the case like an infertility. Once you got the child, it is not a cured case. It will be a cured case of infertility. But in case of thyroid disorder, you can't say once you get a normal result, it is a cured case of thyroid disorder. You have to get a consequent at least 2-3 investigation reports normal for telling that secured case of hypo or hyper or any other thyroid disorder. And I think then it need further explanation. I have already discussed, because from cystic to spongiform, it is worse, and to hypoechoic, again worse, microcalcification, again worse, and in the vice versa, if you are getting this microcalcification disappeared in the next follow-up scan, hypoechoic converted to hyperechoic, and it is considered as a good prognosis. And this thing you can assess by this Thyroid's criteria. You have to definitely go through this Thyroid's criteria, which is very useful for your clinical practice. Next, we can discuss one more case, last one. Here, the level of T3, T4, TSH, I will then show it is a case of, it came as a case of hyperthyroidism to me. With a high level of T3, T4, pre-T3, T4, and a very low level of TSH, and like that, what I have told earlier, like previous case, I have sent the patient for this antimicrosomal antibody or anti-TPO, and it was found that the normal value is up to 34, and it was found that 470, that is, there is a high level of anti-TPO. So there is some this autoimmune process in the background. So with that, I diagnosed a case of Hashimoto's disease, but I have a doubt that it can be a case of Graves' disease also, because the presentation is hyperthyroidism, but the patient couldn't afford that much this investigation cost. So I didn't send the patient for at that time. I didn't send the patient for TSH receptor antibody. I had given the medicine. The medicine given was Silesia. She is a very mild type of personality. That is usually, and psychosophilitic this miasm was predominantly in the background, and I have given Silesia 200 initially, followed with Silesia 1, and as an intercurrent I have given Carcinosin 200 as an intercurrent. And meanwhile, during the treatment she got pregnant. And so when she got pregnant, I have referred the case to the nearby gynecologist. But that's the case. The hospital is nearby a very established government hospital in the Trivandrum area. But they didn't accept the case, and they have referred the patient to medical college, because it comes under high risk pregnancy, because the patient has diagnosed with hyperthyroidism. Hyperthyroidism is a graver condition, already told as compared to hypothyroidism, and the patient. And pregnancy is also a fluid overload state. The most important complication that comes under hyperthyroidism is cardiovascular complication. Along with that, patient got pregnant, there is a more chance of cardiovascular complication is there, and the chance of conversion, that is a transmission of disease to baby, and then stillbirth. The chance of stillbirth is more. So they have referred the case to Medical College Trivandrum, and they have given, and the patient. Went to hospital only after the third month, or only after the fourth month of her pregnancy, and after that she was under my treatment, and it was given and the medicines given was Cyretia and carcinosinous intercurrent. And we have seen the TSH value is increasing. Along with that, there is a decrease in the T3 value. This was the result. And they had sent the patient for this anti-TSH receptor antibody, which is a confirmatory test for Graves' disease, and it was also found positive. So it is a case of Graves' disease, which is a very rare condition. I'm glad that I could treat this patient, and we could give the result with our medicines, our homeopathic system, and she delivered a normal, healthy baby. As a term baby, it is a premature baby is also under one of the complications of this Graves' disease, and but she could deliver a tame baby, and this is a result of that is an intrauterine USG report of the fetus. It is another investigation, intrauterine USG report of fetus, where they have examined where there is a thyromegaly or any other thyroid disorders for the fetus, but it could found that it is normal. It was within normal parameters, and this is the result of baby. That is a baby born to that Graves' disease mother, and it was found totally normal. So it is the beauty of our system. She could deliver a healthy, normal baby with normal thyroid parameters, with normal thyroid gland anatomy also with our medicine. So conclusion, always try to diagnose the condition. So it is very important. You have to be well versed with the diagnosis also. It will help you for making the this evidence based. You can make the investigation, you can make your case evidence based, and do all the investigations and make it evidence based. That is that what I have told about this higher prolactin level in case of this infertility. Like that, you can do all the investigation, and that will help you for the future research purpose, and also for convincing the patient who are coming to your clinic for in future for the same complaint. So you can do all the investigation, and we aim at the cure of disease. So you can always try to give constitutional medicine. Along with that, you can also use these tips for the current alleviation of the symptom, but always try to aim at the cure of the disease, and do follow-up investigation even after the stoppage of medicine. So these are the conclusion. So, dear doctors, accept the challenges so that you can feel the acceleration of victory. So, once you have accept this cases like challenging diseases like Hashimoto's disease or Graves' disease, or once you have got the result, it will accelerate the victory. That is, you will surely, that will be a fuel for your future journey, and that will also help your fellow beings, and also help for your juniors to accept those challenging cases, and also will help you for helping the future generation also. And also it can challenge your friends of other system of medicine, also your friends in our system also. And once you have done that, you will always got this acceleration of victory. So I wish you all a very great success in homeopathy, and all the best. Thank you.
Thank you, Dr. Soumya. Can you hear me, Dr. Soumya? I think Dr. Soumya can't hear me. Dr.
Hello.
Soumya, thank you very much. And let me tell her to look at the question answers. Just before that, I'd like to run a poll to just see what kind of seminars or webinars you'd like to take.
Yeah, now I
Can you
can hear
just
you from another.
can you just take this poll?
Okay.
What kind of webinars you'd like to take, so you can so we'll know how we can identify what webinars you'd like to take. Okay, I'm going to close the poll. Thank you everybody for sharing your answers. Okay, I'll wait for a few more, maybe a minute more for everybody to just fill up this poll. Okay, I'm going to close the poll, please. Thank you. And we'll ask Dr. Samia to look at all your questions and answers and answer them one by one. Yeah. Dr. Samia, there are some questions they have. You got logged out, is it? No, okay, you can just log on again, no problem. You can just log on and will you all just hold on? She's logging back in. She got cut off. She's logging back in, and she's going to take up all your questions one by one. Ah, you can come in, doctor. You see all that? You can just come in. Dr. Samia is just logging back in, so she'll be here with us in a minute. Yeah, yeah, yeah. You can hear me?
See, Doctor, a question
Doctor, can
asked
you
by
hear me
Dr.
now?
Anna. Men are much less likely to suffer from thyroid problem. How do you think?
What constitutional type in men
Can you
have
hear, Doctor?
more thyroid? Yes, yes.
Yeah, yeah, I can hear you.
Okay, you can hear me, doctor. Doctor, can you hear me?
Hello? Hello, can I continue?
Yes.
Yeah, yeah. Ah, okay. What constitution type in men? Yeah, yeah, now I can hear you.
You can hear me now?
Yeah, I can hear you.
Okay. So right from the top, doctor. You can start right from the top. Just scroll up. Yeah.
Oh my God.
The first is Danica. She's asked, why is thyroidinum indicated as a remedy in cases of multiple allergies?
Okay, the question asked by Dr. Anna is uh, men of less much likely to suffer from thyroid problem. How do you think what constitution type in men has got thyroid damage in particular goiter? I think, doctor, these thyroid disorders are more commonly in constitution where there is a in when we are thinking in it philosophically, it is more of a suppression type of constitution, whether it is a this emotional suppression or in the any form of suppression. Like that, if they are not showing their emotions in that type of constitution, even in men, there is a chance of thyroid disorders are more. And the question by Dr. Zeni is anatabin a constitution? No, doctor, it is not a constitution. It is a chemical. It's a type of alkaloid found in Solanaceae family. It is a vegetable family, and you can use this anatabin supplement for controlling this inflammatory action. Then potency and repetition of calcary floor by Dr. Mariam. Calcary floor, it is a remedy. I have already told it is only one remedy that is found under thyroiditis. If you are using a constitutional medicine, then you can use it in a low potency like 6C. Or if you are using calcary floor only, then you can use it in 200 or 1 potency. If like that, if that you are using another remedy along with this calcary floor, you can use in another potency like low potency or this biochemical level of prescription. And another question by Dr. Karthik itself, T3, T4 level are normal, but TSH is elevated. That I have already told doctor, for rise to level of TSH, you can use this Natrimo 200 weekly 1 dose along with pituitinum 30 TDS. Or otherwise, we can use Spongia 30 TDS.
Thank you, doctor. Thank you. One going up.
Then Dr. Karthik, TSH is normal but very high level of anti-thyroid antibody. What remedy would be given? That is anti-thyroid and this antibody elevated also means it's a case of Hashimoto's thyroiditis. It's better to give a constitutional approach. If you are not able to give this constitutional remedy, you can use this anti-mathematic remedy like syphilinum or carcinosinum 200 also. Then another suggestion is sepia 1 along with ambergris 30 BD.
All right. Thank you. And Dr. Akhil.
And Dr. Akhil, what's the size of thyroid nodule that we can treat with homeopathy without referral? It is depending upon the Thyroid's criteria, doctor. If it is a Thyroid's 3 criteria, you can take all nodules up to 2.5 centimeter. Thyroid's 4 criteria, all nodules up to 1.5 centimeter, and Thyroid's 5, all nodules up to 1 centimeter. And also other nodules also you can take, but you have to be wait and watch. You can give the medicine and do the follow-up investigation every 2-3 months. If it is reducing in size, it is safer to take with our medicine. And Dr. Anya, that is if a patient is for many times on hormonal treatment, how to begin homeopathic treatment? Can I cancel and drug and immediately at once? That I've already discussed in one slide. How can get off or tapering the allopathic drug? It is based on the age, sex of the patient. I can surely reduce the or taper the use of this synthetic hormone supplement along with our medicine, or only once you confirm that our medicine has started action. I think almost all questions are over.
Oh, there is one from Dr. Danica. Why is thyroidinum indicated as
radioiodine therapy meant for? Radioiodine therapy, it is using for the case of surgery. They are using, that is radioiodine same as that of radiation, I think. They are using this partial destruction of the gland, so it can lead to future hypothyroid state. So it may be necessary in case of this malignant cases, but once we have given that, the side effect is hypothyroidism, but for saving the patient, it may be necessary for that time.
Doctor, there's one more by Danica. Why is thyroidinum indicated as a remedy in case of multiple allergies? Did you get that, doctor? Did you hear me? Just one more question there. I'll just post it out. Why is thyroidinum
Ah,
indicated?
yeah, doctor.
Why is
What is
thyroidinum
the
indicated
thyroid
as
medication as a remedy in case of multiple allergy?
okay.
Uh, is it doctor? That's the question.
Yeah, this is why that's what she wants to know. Why is thyroidinum indicated as a remedy in multiple allergies? Are you able to hear me, doctor?
Hello.
Hello, can you hear me? Oh, there's one more question. Let me just put this out in the question and answer.
Ah, yeah. Now I can hear you.
You
Yeah, I
can hear.
can hear
There's
you.
one more
Yes.
question that I've just posted by Shivam Gupta. Ma'am, can we?
See, thyroidinum indicates as a remedy in case of multiple allergy. I haven't used that drugs as in case of multiple allergy, but I have seen this patient, this Hashimoto's thyroiditis or any other this autoimmune disorder, the patient is in a hypersensitive state, so it can lead to multiple allergy. Like patient can present with urticaria and multiple food allergy, etc. So it is an organ remedy. It can also indicate it for that presentation also. I think so. So that's why you can use this thyroidina for the multiple allergy. The next question, can we give Drosera to the patient of hypo or hypothyroidism with a personal history of TB lamp? I didn't have such an experience, doctor. Uh,
Yeah. Does anybody else have anything else to ask Dr. Soumya? If you have, can you please type it out in the tab separately so she can take it up one by one? And if you don't have, you can email us at baholainternational@gmail.com to tell us what you felt about
yes.
this webinar and share your feedback with Dr. Soumya and to us so that it will help us improve in our next webinars that we have. I see nobody else has anything else to ask. So with this, I'd like to thank Dr. Soumya. Thank you very much, Dr.
You
Soumya.
can also give my number, I think, doctor.
Yeah, can you wait? Let me give you Dr. Soumya's number. I'll post her email. Yeah, if they want, her number is, I'm just going to type it out in the chat for you. 8547801235. This is Dr. Samya's number. If anybody would like to ask her anything that they saw in this or they have any other doubts they have later on, you can see it. And all those who have registered for this webinar will get an email maybe in a few hours informing you that you can always come back and have a look at this webinar whenever you want, any time of the day, and any number of times. You can view it any number of times, stop it, rewind it, go back, listen to any part of the webinar. And I once again, I'd like to thank Dr. Soumya for this very elaborate webinar on thyroid. I mean, I've not sat and seen such an elaborate webinar yet from a homeopath who can speak as much as an allopath can speak on this subject. And I think a lot of this goes, a lot of thanks should go to Dr. Biju because he has been educating a lot of homeopaths from Kerala to mentor them and make them feel at par with allopaths. When they speak to an allopath, they understand what modern science has to offer. We're going to take the inputs from modern science, but going to use the homeopathic method of uh, finding out the symptom. So, with this, I'd like to say thank you, and we hope to see you uh, every Wednesday. We have a webinar, so you can register uh, with with us when we put out this. Dr. Soumya, what can you share your email address? Okay, let me just give
Yeah,
you Dr.
sure.
Soumya's email address. Okay, there you go. It's
I'll send you my
Soumya. Yeah.
email. Once again, I thank my mentor, Dr. S.G. Biju, for giving me this great opportunity. I thank one and all who are here to listen me, and also I thank Dr. Karthik. Thank you so much.
Okay, thank you very much. So we see you. Bye bye.